Hopefully all goes well. So this talk has changed a little bit in the last month or so, given that we have just passed the Marijuana Tax and Regulation Act on March 31st. So we'll talk a little bit about medical marijuana, its role in symptom management, and in exchange for me talking about some of the medical part, you're going to let me be on my soapbox about some of the social part, that is marijuana criminalization and then decriminalization. So I have no financial disclosures. I am not, in the pockets of big marijuana here. I don't own any stock. I have no ownership. But like I said, very recently, years, if not decades, of advocacy from New York Assemblywoman Crystal Peoples-Stokes, who you see here, and her companion in the Senate, Liz Krueger, have culminated in New York State finally legalizing marijuana. And we still have a lot to see how that's going to shake out. But we'll talk a little bit about what we know so far. And to really understand where we are today in terms of our access to marijuana and our understanding of it, we have to go back a little bit to figure out how we went from a period of, cocaine in our soda and treating colicky babies with heroin to this, era of mass incarceration we have for marijuana possession. Anyone who's paid attention knows just how strongly various folks feel about marijuana, from parades and rallies for legalization, people really focusing on patients' rights, that there is this medicine out there that you are denying us. And the other side, most more moderate, and some truly feeling like marijuana is this gateway to, all evils that might be out there. And this journey first starts back in the early 1900s. Here you see, one of the former medicines, if you will, that used to exist before regulations, where infant relief would include cannabis, chloroform even, trying to get kids through their colic. And back in early 1900s, particularly at the urging of the Catholic Church, there was this push to crack down on what was seen as immorality or amorality, really looking at some of the opium dens in the Philippines that we, acquired is a kind word for after the Spanish-American War. Folks on missionary trips would see the opium dens there and say, look at this, this is a travesty. We need to push the international community to regulate this more. And so the State Department got involved, international groups came together, and that culminated in the US in the Harrison Narcotics Tax Act, which created the Federal Bureau of Narcotics. Along this push of legislating moral decisions came the temperance movement. And again, this was really not about medicine. This was about morality and also protecting the vulnerable in our community. So the temperance movement was really based in women fighting for this and trying to protect women and children from alcoholic men. However, in 1933, when Prohibition ended, we also found ourselves in the middle of the Great Depression, and we were trying to find someone to put some of our blame on to displace that frustration we were feeling, and we again turned to this common scapegoat of intoxication. As part of this, Harry Anslinger, who was the head of the Federal Bureau of Narcotics at the time, created what got called the Gore Files, a collection of 200 news stories that claimed marijuana was involved in these really horrific, violent acts. Mixed with this, he had his own little share of racism that clearly informed his policies. And he mixed those together to have a racist news push claiming that immigrants, African Americans, were smoking marijuana and turning into murderers. And this culminated in the Marijuana Tax Act that went in 1937. That essentially made marijuana illegal. It really placed a tax on marijuana if it were ever used, sold, prescribed, and because of individual states having their own regulations around this, it was essentially illegal. This faced a lot of legal battles over the coming 3 decades, and ultimately in 1969 it was ruled unconstitutional because it required you to register with the federal government and pay a tax that would incriminate you for a state illegal activity. So it was an interesting point of federalism there, that we quickly found a way to fix the loophole, and in 1970 we passed our Controlled Substances Act. This combined with Nixon's war on drugs, which was in the end a really blatant attempt to criminalize and vilify his enemies. So he really had struggled with the anti-war left and African Americans. They just didn't want to vote for him. And instead of trying to win them over, he decided to take something that he could associate with them. So by associating heroin use with African Americans and marijuana use with the anti-war left, with hippies, and criminalizing that and really just dragging these folks across the evening news every night, he could really push that group of folks off to the side. Jimmy Carter ran on decriminalization, didn't get through the Congress, and then Reagan once again appealed to this sort of morality that is not using drugs. That being said, this fear-mongering, racism that went into this is not the only thing. We also flew in the face of medical advice. Right after the Marijuana Tax Act, LaGuardia, the mayor of New York City at the time, had actually had a 5-year study happen on the effects of marijuana in New York City. And it showed, it was put out by the New York Academy of Medicine, and it showed no signs that this was a gateway drug, no signs that it was contributing to crime, and that the publicity concerning the catastrophic effects of marijuana are unfounded, really going against the yellow journalism push of the Marijuana Tax Act at the time. Part of the Controlled Substances Act created the Schaefer Commission to look at whether or not marijuana deserved to be Schedule I. It was only supposed to be this temporary designation as a Schedule I drug until we get more data. Unfortunately, the Schaefer Commission came out and said, gosh, the harms of this just aren't enough to justify criminalizing personal behavior. And yet, the Nixon administration said, I just don't believe you. And it was non-binding, and they kept it a Schedule I. After, again, lots of pushes for the federal government to revisit whether or not marijuana really should be Schedule I, which is essentially saying it has no medical, known medical benefits and high risk of abuse and harm. In 1988, well, actually it started in 1986. It was a 2-year hearing. Lots of medical opinions, lots of professionals testifying on this. And they came out and said, you know, it is unreasonable, arbitrary, and capricious, which my lawyer sister tells me is just dumb. It's a legal term saying that this is absurd. For the DEA to stand between sufferers and the benefits of this substance in light of the evidence. And this was an official ruling in the DEA, but it's a non-binding ruling by a DEA judge. And the administrator of the DEA at the time, still in the Reagan administration, said, I disagree. And so another example of years of professional testimony and input being put on the record, and then somebody overruling and saying, I just don't believe that. So none of this moved the needle in marijuana legalization. Although in 1998, California passed its first medical marijuana law, and it had nothing to do with, professionals going on the record. It again came back to needing to protect somebody, needing to protect women and children, particularly children. So this is Charlotte Figge, who has a very rare epilepsy, Dravet syndrome. And it was through her story, a lot of the advocacy around specific patients. Charlotte went from having 300 seizures a day to 1 seizure a week. And it was found that this marijuana that was very CBD heavy, so marijuana has THC and CBD, and CBD in particular made a huge difference in Charlotte Figge's life. And, individual anecdotes like this is what really pushed huge referendums in the state. Some states actually doing it through Congress or through their legislature. She even had a CBD heavy strain of marijuana named after her, Charlotte's Web. She unfortunately, I believe, died from COVID this past year. Another case here, Amanda Hauser is next to Governor Cuomo when he signed his medical marijuana law here in New York State. So it's really heavily in this, how do we protect children, is what pushed medical marijuana. That didn't undo the decades of racist, discriminatory drug practices. And if you look at incarceration levels over the decades, you can see that inflection points on this graph are really our declaration of a war on drugs and the Sentencing Reform Act that pushed mandatory minimums out there and really went after drug offenders. There are wonderful documentaries that go into this in much more depth. But what's really interesting is that there's this mentality out there, perception, that African Americans are pushing this, and the use rates are actually higher among Caucasians. So looking at young adults here, more white folks than black folks are smoking marijuana, and by 4 times more black people are getting arrested for it. So it's just an incredibly disproportionate, systemic racist way we are going about our drug enforcement. And what this ends up saying is that in 2018, about 10 million arrests, 1.6 million were for drug violations, almost half of that marijuana, and 92% of marijuana arrests were just for possession. So that ends up with 7% of all of our state inmates are behind bars for marijuana possession, which this social justice is really what's pushing the legalization front. So whereas that, how do we protect our children who need this medicine, pushed medical marijuana, the legalization push now is much more around this idea of social justice and the unfair, discriminatory way that we are using our drug laws. This has culminated in what is currently our legalization map here. The really dark green are fully legalized states, which we have now joined. The other shades of green are some level of medical marijuana being available, decriminalization, which removes the jail time, but still retains fines for things. And then some states are still fully illegal. Just a very brief overview of what our laws currently are. The new law created what gets called this Office of Cannabis Management. And as most laws are, it creates a bureaucracy that will eventually decide the nuances. Instead of legislating all the nuances, it said we leave up to this Office of Cannabis Management to figure out the fine details. What it does say is that there's going to be a 13% tax on adult use marijuana, with most of it going to the municipality. It designates where that money is going to go. And as we look at how we build, the initial legalization process in the early states was really criticized as leaving out African-American communities from this new business. So we created a business that was much easier for wealthy white folks to start up in. It was a really high cost, high overhead business to start. And so we effectively further marginalized this group of folks despite our legalization. So in New York, the lawmakers have, at least in stated intention, tried really hard to make an anti-racist component to their laws. So there is 40% of the tax revenue going to community grants, reinvesting in the communities. They also create social and economic equity programs so that equity applicants for licensing get priority, or there are a specific number set aside for equity applicants. They have access to low interest loans, some fees are waived. And there is, in theory, a plan to expand the medical marijuana program that exists. What the current regulations are around medical marijuana, some of you may already know. There are certain conditions that you have to have in New York State. This varies by state. Some are very restrictive with something like 5 conditions. Some have dozens. Here, I know, I'm talking to Gilda's Club, so everyone here is going to be qualifying for their cancer. And then you need some sort of symptom that comes with it. Things like nausea, pain are the far and away most common. You'll note that anorexia, not wanting to eat, really isn't on here. That cachexia wasting syndrome, gosh, that's more severe than we would say, I'm just, we're losing a little bit of weight. Cachexia and wasting is really what gets associated with HIV and AIDS. But most people can qualify from some level of nausea and pain, is what we would often end up certifying folks with cancer for. The question does arise, gosh, if it is legal, why would I ever get certified? Which is a fair question. And then some of this still remains to be seen. What is most interesting to me is that we have now designated being a certified medical marijuana patient as a disability with New York State. So all of the same protections that you would have for other disabilities now pertain to you as a certified medical marijuana patient. This means that although your job can say you can't use on the job, you can't be fired or denied hire because you use marijuana. You certainly could be told you can't drive your forklift while you're using your medical marijuana, but they can't say you can't do that when you go home. It can't be used as a consideration in domestic family court, so you can't be told because you're a marijuana patient you shouldn't have the same custodial rights. You can't be evicted from your apartment. They're allowed to have no smoking rules, so they can say you can't smoke anything, but they can't say you can't use marijuana in my property. And then even universities aren't allowed to deny acceptance to students because of marijuana use, unless their institution has a firmly held religious belief that is codified in their code of conduct. So you need a religious exemption to discriminate against marijuana use, which is interesting. And also notably, this Office of Cannabis Management allows for some price fixing. So they would, there's nothing out there about how this is going to be used, but it would allow for them to set the price of legal marijuana differently from medical marijuana. If nothing else, that 13% tax I mentioned is only being levied on adult use recreational marijuana. So there will almost certainly be a cost advantage to being certified for medical marijuana, if only avoiding the tax. The other side of this, people really worry that liberalization of marijuana rules is going to be, again, we need to protect our children. And gosh, we can't go down this policy because it's going to lead to rampant drug use of our children. So there's a Monitoring the Future study that goes out of the University of Michigan that is a nationwide risky behavior study. And has the best longitudinal data on this I can find. And it looks at the use patterns of marijuana over decades here, looking at 8th graders, 10th graders, and 12th graders. And over the last 20, 30 years, where we have seen a fairly significant increase in adult use of marijuana and a huge push towards liberalization of medical and recreational marijuana laws, we have not moved the needle. We have not changed our teen use of marijuana at all. Most notably, actually, here is these children are asked to rate how available, how easily could I get marijuana? And the other argument is that if we make these things really available, our children are going to have more access to it. And that's been shown to be blatantly wrong here. You actually see over the last 4 years a dramatic drop-off in the perceived availability of marijuana to our children, which is impressive, surprising. I don't want to claim that that is because of, illicit markets drying up in the face of legal markets. I'm not that naive to think that they will disappear, but we are certainly not ever improving or increasing access to marijuana to our children. And the other part of this, are they using other substances because we're making, if you legalize marijuana, make medical marijuana more common, are children going to think that drugs are fine, not just marijuana? And we haven't seen any increase in the use of other illicit substances in their lifetime or in the past 12 months. If you really dig down into this data, you do see that vaping has increased in the last couple of years of teens, but that is only because it is a new substance, a new thing. And so more teens are vaping marijuana, but more teens are not using marijuana. It's just that their use has switched from smoked to vaped. The other thing that people bring up is traffic safety, and that this data is really confusing. Please don't get too bogged down in it. And I only bring it up as a counterpoint to my firmly held social justice belief that legalization is appropriate. People will point to a very small increase in traffic accidents immediately after legalization, more pronounced on weekends. And for most states that this was studied, that slight jump up in traffic accidents, here each state you'll see, the specific points there in dark black are the data point for each month with the wavy line, that sinusoid showing an average trend, and then the line being the the straight line being a model of averages there. And you can see the pre-legalization to post-legalization trend line, and there's often a bit of a step up in that trend line right at legalization. And you also see that that tends to then decrease back to where we were before legalization. So it's possible that there is this phenomenon out there that people talk about where when you all of a sudden have access, there are people who go out, try it, don't know how it affects them, and still drive. And it looks like we learn over time. It's something to be aware of, something to caution folks about, and is not enough of a reason to say that this is inappropriate, in my mind. We'll do a quick scientific background here. I've already used up a fair amount of time. Cannabinoid receptors are found throughout the body. They were first discovered back in '92 by an Israeli scientist named Meshulam. And there's two different flavors to this receptor. One we see just throughout the body, primarily in the nerve system, and then the CB2 receptor we see in a lot of immune cells. So we see a lot in the spleen and the white blood cells, and again throughout the body. And we've first identified endocannabinoids, so this chemical that is in our body endogenously that gets released for various reasons. We then discovered that this marijuana plant has phytocannabinoids, substances that are in this plant that hit the same receptors. So we primarily talk about THC and CBD, 9-tetrahydrocannabinol and cannabidiol. And then there's other phytocannabinoids that seem to play less of a role. And marijuana also has hundreds of other chemicals in it. And this huge list of chemicals is part of what makes studying it really hard, because it is not a single drug that we get to isolate and study the effects of. So it is dirty when we do the studies. But we have created a few synthetic medications that have actually made it through FDA approval. So dronabinol is a synthetic THC that is sometimes prescribed for primarily nausea. Chemotherapy-induced nausea, I believe, is its only FDA approval, but will sometimes get used for appetite. Nabilone is also a synthetic THC. Nabiximols does not yet have FDA approval. It is used in Europe, but is a combination of THC and CBD. And then Epidiolex is an FDA-approved medication for epilepsy. It has just CBD in it. And we've seen an explosion of research into marijuana over the last several years here. So we used to have nothing to go off of, and we're starting to have more and more. A quick look at some of the data out there that exists. There was this big systematic review back in 2015 that looked at 23,000 different references, pulled 500 full reports to look at, found a bunch of randomized controlled trials, which are really seen as the best out there for data that we have. And it looked at primarily pain and nausea and vomiting. However, we then looked at what's the risk level of bias for these various studies, and very few of them seemed to be really consistent, low risk bias, and very few of them actually looked at smoking pot. We looked at these various medications that have been approved. So the question of whether or not using medical marijuana is effective is a little bit hard to answer. Not impossible. This study that I just talked about pooled all of this data around pain, and this gets called, we don't need to get into it. At any rate, what this plot shows is all the different studies, and things to the right of the central line say that the study is saying cannabinoid probably helpful for pain. To the left of the center line says the placebo did that just as well. And so then we pool all of these individual studies together and say we're fairly sure that the real effect is somewhere in this diamond here. So we are not 100% positive, we never are in medicine, but we are fairly sure that marijuana for all comers helps a little bit for pain. My anecdotal evidence, my thoughts initially from caring for patients firsthand, are that there are people who respond really well and people who don't respond at all. And so this average of a very small difference is probably a big difference for some and no difference for others. Yeah. I really like this study that comes out of Canada. They have an app-based system. It's a phone app that you can use that you input which strain of marijuana you're using and what symptom you're targeting. And so this is not a controlled scientific study. This is people using their phone and just documenting their own use patterns. But you have thousands of people in this, and which symptoms they're trying to treat here. Let me get my pointer back. So you can see, of all the symptoms, people are trying to hit their anxiety the most, insomnia the most. And this column is individual people, and then over here a number of uses. So again, 9,000 times we have logged the effect of marijuana on anxiety, 3,000 on neuropathic pain, nerve pain. And the person using the app then says, before I used it, how bad are my symptoms? After I used it, what are my symptoms? And you get how many people showed improvement. And you can see that pain is actually one of the less likely, although 40% of people got improvement from pain using their marijuana. But anorexia, PTSD flashbacks, insomnia, anxiety, all of this showed reasonable improvement, but again, not everybody. Looking at this table, the odds ratios explain really basic. What this is looking at is how much does the THC component matter. So these people are logging how much CBD and THC are in their product. They're actually putting in a product and the program knows what the ratios are, but trying to get a sense of how much of a difference does the THC make for the fact that they got improvement. And it looks like for neuropathic pain and insomnia, it made the biggest difference. Numbers above 1 mean that it made a big difference. A number like 1.13 for anxiety means that it really didn't make a big difference. People, you can now see the graph here that this comes from. Looking at insomnia, gosh, with very little THC, only 20% showed benefit. And here with a lot of THC, we got up over 40. And so how likely you are to see benefit for insomnia made a big difference, how much THC there was. Anxiety is here with the squares, started about 60 and stayed pretty constant. So the ratio there didn't have much of an impact on how likely people were to get benefit from it. But again, this is all very individual. And when I talk to patients, I say, everybody responds differently, and we need to figure out how your body responds to the different components, the CBD and THC. And for people who say, gosh, I smoked and then I got really anxious, I was worried, this was going to happen, that was going to happen, that seems to be related to the THC, and people do better with lower THC products if they feel a lot of anxiety when they used marijuana. And people who are primarily treating anxiety, I point them more toward lower THC products, more CBD, because they seem to have just as much benefit and have some less of that head high that they may or may not want. Specifically looking at anxiety, this graph that is a bit confusing to look at is something called the visual analog mood scale. And so it's just a way that we, in research studies, look at how anxious somebody is. And this is a simulated public speaking exercise. And so everybody in the study got up and spoke in front of everybody else in the study. And they were given either a placebo, sugar pill, some amount of CBD, or clonazepam, which is a benzo, which is a common medicine to give for anxiety, and a pretty big gun. And so you take their anxiety levels at baseline, right before they get on stage, in the middle of their public speaking, and then afterwards. And so in the middle of their public speaking, you see everyone got more anxious. The clonazepam, very little. And up here, you have high and low dose CBD along with placebo, all had the most anxiety. And then this medium dose CBD had some benefit. Not as much as a benzodiazepine, but less anxiety during their public speaking. So we know that cancer treatment and going through cancer is a lot of anxiety, and some situational anxiety that's certainly not public speaking, but think about going for your scans, or that day or two between when you get your scan and when you talk with the doctor, and the thoughts that go through your head, and how everybody gets anxious during those times. And so it's possible that we're making a difference there. I want to touch on this just because everybody asks. There's so much research out there about whether or not marijuana is curing my cancer. And this is a really good review article of it, looking at all the different theoretic ways that cannabinoids might interact with all of these different pathways that are involved in cancer. This looks at, from the same article, all of the different types of cancers out there, from myeloma, glioma, leukemia, breast cancer, that there is some sort of study looking at marijuana use and actually treating that cancer with marijuana and standard treatment. So this middle part are the standard treatments with which we are combining THC, CBD, or some combination. That being said, the blue is just in vitro studies, so a cell culture. This red is a mouse. And then the green is the first one that's actually in humans, but it's a very early trial, and I actually couldn't find this data anywhere that's published. It was just in a press release from the drug company. So I'm always a little skeptical about what a drug company is willing to publicize without actually publishing the data for it. And most importantly, lest we get too excited, this is a really nice quote from one of the old National Cancer Institute directors, saying that the history of cancer research has been curing cancer in the mouse. And we have had so many really promising drugs that did not pan out. And if you look at how likely different trials are to fail, based on where we are, preclinical trials, all those trials in the blue on the last page, 60 to 80% chance that those drugs never make it to the market despite initial good findings. And even the things that reach phase 3, which is those big human randomized controlled trials, still only a 50, 60% chance that those get FDA approved. So there's absolutely exciting research out there that maybe marijuana is helping with specific cancers in conjunction with standard treatment. But I would never tell patients that the marijuana is likely to make a difference, because we've just seen too many things work in a mouse that don't work in a human. And I would be really nervous about using those instead of standard therapies, because everything being studied is in addition to the standard therapy. That is all I have to talk about, and I wanted to make sure I left plenty of time for questions. I know my first caveat here is that I want to be careful as I answer questions. I'm really should only answer general questions. I can answer questions as a physician, but not as your physician, because I don't know your specific history, and we don't have a patient-doctor relationship, so I shouldn't ethically give medical advice to you, but I will be glad to give what is general advice for people in your situation. I know some questions came in early that I'll address up front. This question, I hope it was clear that I think marijuana helps a number of people and not everybody. And I have patients who tell me, gosh, this was the miracle drug. This is the thing that prevented me from needing to take opioids like morphine. This is the thing that helped me eat again and is giving me my strength. And I have a lot of people who spend $100 on it, get no benefit, and never turn to it again. So we try. It's a reasonable thing to try for a lot of folks. And if it doesn't work, we have to do other things. Just like any of the medications I prescribe might not be the one for you. Marijuana might not be the one for you. It's reasonable to try a couple different concentrations, ratios of CBD to THC, but it's not a guarantee. It's not like you have to find the perfect ratio out there for you. You may not find it. There was a question about traumatic brain injury, and I appreciate the question, actually. I hadn't looked into this at all. And as part of preparing for this, I saw that there is certainly a lot of interest in the neuroprotective properties of THC, marijuana, and its impact on outcomes in stroke, in TBI, traumatic brain injury. And the best guidance out there is that it is very mixed. So it would depend a little bit on what we are trying to improve with marijuana and the traumatic brain injury, and what we're worried about negative aspects. There would be there's this thought out there of the motivation that comes with marijuana, because we have this picture of, gosh, this friend in high school who started smoking a lot of pot and never did anything. And, so much of recovery from cancer, from brain injury, from anything, is that motivation to participate in therapy, physical therapy, moving. And I do not have, I maybe have one who had used a fair amount of marijuana prior to coming to me. But for the most part, medical marijuana at the amounts we're using to treat symptoms is not the amount that is ever going to prevent somebody from doing their therapies, and is hopefully going to get symptoms well enough controlled that they're doing their therapies. And that is always my goal as their clinician, is to treat symptoms well enough that you can actually participate in things. And if I am giving you so much pain medicine, you're too sleepy to do things. Or if I'm giving you so much marijuana, you're too sleepy, apathetic, that you're not doing it, we're doing the wrong thing. That being said, it is not clear to me from reading what I could find whether someone with an established brain injury is likely to get any benefit in terms of like neuro recovery from using marijuana. There is let me just pull up. The American Psychological Association had an article put out on this in 2016 that I really liked, called Weighing the Risks and Benefits of Using Medical Cannabis in the Treatment of Neurocognitive Disorders. And so the American Psychological Association was at least interested enough in the use of marijuana in stroke and traumatic brain injury to say this merits a lot of study and we need to learn more, but we just don't know. We have to be careful that we're not causing harms. So I wouldn't go out of my way to use it. I would use in moderation if it's being helpful. And if it's not obviously helpful, I don't see a big push to use it. I hope that answers the question. And if people want to give more insight to help answer specific questions better, I'm happy to do that. If you direct questions to me directly, we can anonymize it in a way that I won't call you out. or you can just speak up and I'm happy to answer the questions you have. And if there's any aspect to this I didn't touch on that you wish I had, specific patient populations, we could talk about immunotherapy and the nuance there because it comes up a lot.
Well, we had two questions actually. The first one would be, how was the marijuana ingested in the studies?
All sorts of different ways. So a lot of the studies that were in that 2015 review article were capsules, because you're looking at FDA approved medications. If you look at the CBD studies are generally capsules. The other things look a lot at tinctures. And if you go to one of the dispensaries in Rochester here, far and away the most common way for people to use marijuana is vaping. And I discourage everyone from vaping because we still don't know everything about vaping associated lung injury. If you look at, depending on how you look at it, you would have people say, well, no, that's just an adulterant. As long as I get it through an established dispensary, I'm fine. And if you look at the data from California, 10% or something of products that you might get from an established dispensary are what you might call counterfeit. So the regulation is really just, it hasn't caught up yet. But yeah, so it's been studied primarily in easier to control capsules because we have the best understanding of like what is in that capsule, and you're not stuck with, well, this dropper or how much of the smoke did they inhale, that kind of thing. But you had a second question.
What about the risk of cancer? Does that go up with use?
Yeah, not as best as we know. Again, this gets to how you use it. And the initial thought was certainly, if you think logically, inhaling hot vapor into your lungs is probably bad for your lungs. So I would hesitate to tell anybody that your risk of cancer is going down or even staying flat while chronically injuring your lungs a little bit. That being said, there's not been any clear evidence that suggests that marijuana smokers are at higher risk of any cancer. There was a big study out of California looking at a population's risk of cancer and their smoking. And certainly it reconfirmed that smoking cigarettes put you at risk for cancer. Because people who smoked marijuana were more likely to smoke cigarettes, people who smoked marijuana were more likely to have cancer. But if you did calculations to try and, figure out how much of that risk came from the marijuana and how much was the cigarettes they were smoking, it actually seemed, I want to be careful. The data made it look like people who only smoked marijuana had lower rates of lung cancer than people who didn't smoke at all. And I really doubt that smoking marijuana lowers your risk of lung cancer. The data does not prove that. But there was certainly not an increase in lung cancer in folks who were only using marijuana.
I don't want to take over if other people have questions. I do have one more. What is the benefit of having a synthetic marijuana versus the naturally grown?
Do you mean in terms of the prescribed medications that are synthetic?
Right. Like, why wouldn't you go for what came from the ground versus creating these synthetic products that could potentially not be recognized by our bodies naturally?
Yeah, that's a very fair question. Similar to with opioids, so the pain medicines we use, there are some things that are naturally derived. So codeine, morphine, those are all natural. And then things like oxycodone, hydromorphone, fentanyl are all semi-synthetic or synthetic. Our bodies seem to respond to them fairly similarly. That being said, most of the time we are sort of creating medications in a test tube. It's to try and get specific properties to it. And I don't know if there are real benefits to having made THC in a lab. What I would say is practically the difference is insurance. So because marijuana, the plant, is federally illegal, insurance is never going to touch it. And so it's expensive. And so when I am using something like dronabinol, the synthetic THC, it's because I think marijuana might be helpful and my patient just can't afford medical marijuana, or they're in a hospital setting where I can't let them use it. And we try. So insurance could potentially cover it. So instead of paying $100 for medical marijuana, you get insurance to completely cover Marinol. But we think in the medical community that there's probably what gets called a chaperone effect. So it's not, even if the THC is doing the majority of the heavy lifting, there's benefit to having its chaperone, the CBD, along with it. So people who use dronabinol are more likely to experience, dysphoria. So instead of euphoria, where you feel really good, some people on dronabinol will sort of feel a little down, muted. But some people benefit from it. And there are studies looking at dronabinol in acute pain. Again, it's sort of these practical applications of the FDA is more apt to approve these more highly controlled, made in a lab medications. And for that reason, it's easier to study them. But for me, the biggest one is if you go out and smoke the flower, there's a lot that you're getting from it. There's a lot of those substances that we just don't know as much about. And if I use one of the extracts, the more, I know the ratios, I know the amounts, cool. And I think I don't see a reason that it needs to go through a fancy lab. Although interestingly, dronabinol is a Schedule II despite being a synthetic THC, and actual THC is a Schedule I. It's a weird nuance.
Thank you.
Vermilion, I do have a couple other questions that came in through the chat. First one is it common that metastatic cancer patients transition from chronic pain narcotics to medical marijuana? I'm interested in transitioning because I'm tired of the narcotic side effects and would like to explore alternative pain management remedies.
Yeah, so this comes up a lot, the question of, is marijuana going to lower the amount of narcotics people need? Is it going to replace narcotics? I think that there is certainly hope that that is true. We have a lot of folks in this sort of cancer survival stage where they had gotten started on narcotics during their cancer treatment and are stuck with this chronic pain and maybe on chronic narcotics, and how do we get them off of that? It's possible that replacing that with marijuana either helps lower the dose of pain medicine opioid that you end up needing. It might be able to completely replace it. And it is probably better in the long run. It probably has fewer long-term side effects than chronic opioid use. But yes, so if you are not sure how to get certified for that, seeing a palliative care doc, most of us would be able to do so. Your oncologist should be able to point you in the right direction, and certainly Wilmot here has a nurse practitioner who does marijuana certification. And for chronic pain, we can certainly certify. It's an appropriate condition.
Great, thank you. Our next question in the chat box says, I understand what THC can do, but my knowledge of CBD is limited. With CBD being marketed by corporate America, could you help me understand what CBD is and what possible benefits it may be for anxiety and depression? Also, what impact does THC and CBD have on kidney function and kidneys? since kidneys are stressed under normal cancer treatments to begin with?
Yeah, the easy part of that, the kidney part, is that almost none. There is no reason for folks with kidney disease to be concerned about using marijuana. It is not metabolized or gotten rid of by the kidneys, so you don't need to worry about it building up in your system like some medications do in renal failure. And so even for folks who are on dialysis, it would be generally considered safe. That being said, I encourage you to tell your nephrologist, your kidney doctor, if you have actual kidney disease, just so that they know. With regard to CBD, this was a booming industry starting in 2018, because prior to that, CBD was considered part of marijuana in the Controlled Substances Act, and as part of the 2018 Farm Bill, they just sort of slid in this provision that reclassified CBD as no longer marijuana. So it became legal without any sort of legal framework around it. It's not regulated like a supplement. It's not regulated like an over-the-counter medicine. So it's in this really weird, nebulous gray zone that the FDA is essentially saying, like, look, there's a lot of money on the line here. We don't want to mess this up. We're going to figure it out. We're going to figure out how to regulate this. And in the meantime, we're really only going to go after the really bad actors. So you can make some claims with CBD that aren't fully supported, but as long as you're not claiming that you're curing, you know, cancer and all sorts of things, they're not going to go after you. That being said, the research for CBD is coming. What people most often talk about it for is anxiety, lots of dog anxiety being treated with CBD chews. And again, you know, we have these studies looking at sort of public speaking, maybe CBD is helping with that. Social anxiety, maybe. We don't have good sort of randomized controlled trials, that gold standard of evidence for CBD. And the other thing people use it a lot for is arthritis. This is another area where I think it is probably going to show benefit. We have a lot of anti-inflammatory benefits to CBD that we've seen in sort of cell cultures. And then the best study I've seen for arthritis, I'm sorry for animal activists out there, but the best study in rats, they actually take these rats and inject their knees with something to give them arthritis. So they inject this substance into the knee, it inflames up and is a nice little model for arthritis. And they take that rat knee and they rub CBD on it. And the rats that got CBD, their knees shrank, and they watched how much that rat ran around their little environment. And the rats who got CBD rubbed on their knees ran around more. So this is our best model for something like a CBD cream or ointment being used for arthritis and actually helping with the inflammation, the swelling that comes with that, and the pain and the limiting your activity that comes with that. So the best I have learned, CBD is probably most helpful for things like anxiety and arthritis. Anxiety, certainly by ingesting it. Arthritis, probably topically. And we don't have the really convincing data out there that would push me to go out of my way to recommend it. And things like that, I often would tell patients if they've established with me that they would prefer a more creative approach to their symptoms. You know, that is often the way that we would approach marijuana, is that it is typically a good second or third line treatment. It's not the first thing I recommend for people. And for certain people who would prefer to try and get away with more natural solutions, try and get away from popping pills, I'm happy to talk as a first line, as that first step about some of these things.
Deborah, did you have a question?
I did. If you're done with the people coming in on chat, I wanted to ask, is it okay if I ask just a couple things? Being a cancer, leukemia person, my oncologist agrees totally with you about the CBD vaping. She advised against it. So I did get my license or whatever, I think it's a license, and worked with my nurse practitioner through Wilmot. And I wondered, how long would you recommend a person try the CBD? Because I'm one of those that are not like the rat. I don't respond to almost anything. I've got a lot of allergies. I have leukemia that I've been on heavy duty treatment for a year, and I have severe spinal stenosis, almost top and bottom, and degenerative disc. I am in more pain now than ever, and I don't want to do back surgery. I took the very last thing I tried in November was just plain hemp extract from the pharmacy. Is that hemp the same thing as CBD oil?
Yeah, so hemp, the difference between marijuana and hemp is all about how much CBD versus THC there is, and anything with more than 0.3% THC gets called marijuana, and less than that is hemp. And through sort of mixing plants over the ages, these distinctions have become harder, but something that would call itself a hemp extract is by theory less than 0.3% THC. It may have the tiniest little bit still in there. And so you've been using something CBD. And I will admit that historically I had told patients that with pain, I think the CBD is what's doing the heavy lifting. Some of the studies would point to more THC being more helpful. Some patients actually say, very self-aware, it's not, my pain is there, but I just don't care about it. And so it's a bit of a dissociation from their pain that is helpful, more than a relief. And this should work quickly if it's going to work.
Yeah, that's what I thought. I started out with 1-to-1 ratio. This was in August. And then in September, I went to the 20T to 1C, which did absolutely nothing. And I increased it as well. And then I went to just the 2-to-1. And then I thought, let me just try the plain CBD oil. So I got the brand from the pharmacy in Rochester, and it didn't do anything. I thought, well, let me try rubbing it on my knee. I was really having a knee issue, but I didn't seem to notice anything. And I am really discouraged because I'm one of those that are on a maintenance of hydrocodone. I don't like taking it 3 times a day, but now it's the pain in my spine is so bad that I just don't know what to do. I was really hoping on this being the miracle for me, the medical marijuana, but not to discourage anyone. I think everyone needs to try it, but for myself, sadly, it didn't help. And 6 months, is that long enough trial?
That is absolutely a long enough trial, and I wish you had stopped wasting your money sooner. I'm sorry.
It's all right.
People in your position, who are suffering and just can't find relief, perfect people to try marijuana. And
Yep.
we have to accept defeat, honestly, much sooner. It's very reasonable to try a couple different strengths, a couple different ratios, but it's something that acts really quickly. It doesn't take, weeks, months. It's not that kind of medicine.
Okay.
And I wish it were going to give you more relief, and it's just not going to.
Yeah, so there's no sense trying it again because it probably won't help.
Unfortunately not.
Yeah, okay. Thank you so much.
I know we are out of time, but if there's anything pressing, I can spend a couple more minutes.
We did just have one other question. The doctor's name or the nurse practitioner that you were talking about that's at Wilmot, could you share that name with us? Somebody asked about that in the chat.
Yeah, Patty Malaber. Your oncologist would know
Yes.
her.
That's who I went.
Yeah, she does a lot with marijuana. She gives this talk sometimes. So she is very knowledgeable about what would or potentially could help you.
Thank you. Does anybody else have any other questions before we wrap up?
Thank you for an outstanding talk.
Thank you.
Yes, thank you, Dr. Vermilion. We really appreciate you taking time out of your day today to do this and offer great information for our members. And we'll have this available for you on YouTube too, for everybody to take a look back at if they need to. So thank you so much. And thank you everybody for joining us as well.
Thank you.